So hearty welcome from the ISG for our now 17th webinar. I hope you like it. Hope it's not the first one you're participating and you have some experience already. And you also agree that these are really wonderful meetings with worldwide fantastic speakers. Hopefully this will be also the case. No, I'm quite sure that will be the case also in Behçet's disease, which is a topic of the day. Again, after the meeting, you will get an evaluation form. Please send that back, and then we will send you in between a week the CME points. That's all you have to do. And probably you will check what the next one is in a month. Then we go to number 18. We have 20 now planned, 20 webinars. More is coming then with November. We have a summer break there. And we probably also will tell you a little bit what we are doing in our summertime in August, organizing the International Symposium on Uveitis. And you're heartily welcome to participate in that one. It's end of August. It's actually all also on our website. Okay, Vishali, can I give you
Thank you.
head?
Thank you, Manfred, and thank you everybody being a part of it. 17 months now, and it's been a total pleasure having you with us on the last Sunday of every month. Sorry, first Sunday. So the first one, we go on with a very difficult disease today, Behçet's disease, which we all find very, very difficult to manage. And we, of course, today have the world-class experts who will give us insights and help us in better management of these very complex patients. To begin with, we have the honor of today having Ahmed Kul with us, who is going to talk about immunogenetic pathogenesis of Behçet's disease. Over to you.
Well, thank you, Vishali. First, I'd like to start by thanking you and Manfred for the kind invitation. It's really a pleasure to talk on immunogenetic basis of Behçet's disease pathogenesis. So my talk will focus on the complex or multifactorial nature of the disease, and I will mainly discuss the HLA and non-HLA polymorphisms causing a susceptibility to the Behçet's disease, and I have nothing to declare relevant to this talk. Well, Behçet's disease has a significant post-predisposition, especially familial aggregation with a lambda S value between 11 to 52 is suggesting a strong familial aggregation. And also the analysis of juvenile patients suggests almost autosomal recessively inheritance pattern if you look at the number of familial cases. So there is a familial aggregation. Also, the geographic distribution of the disease has a peculiar way. It's mainly concentrated on the Eastern Mediterranean and on Silk Road going up to China, Korea, and Japan. And in 1973, Shigeaki Ono and colleagues showed the first HLA association with HLA B51. Later, it was recognized that it's actually overlapping with the distribution of this HLA allele in these populations. Well, HLA B51 is a very old HLA allele. It's actually a Neanderthal HLA allele. Analysis of some Neanderthal DNA revealed some HLA alleles, and B51 is among them. And if you look at the distribution of HLA B51 in healthy population, it overlaps dramatically with the distribution of Behçet's disease in the world. It's mainly focused in the Eastern Mediterranean countries. Anatolia, Turkey is the highest figure, and it's going up to Japan. And if you compare it with HLA C16, which is another HLA allele in linkage disequilibrium B51, but it is not as strongly associated with Behçet's disease as B51, this association is diminishing. So it is definitely associated with B51. And again, if you look at the JIVA studies, including our Turkish series and Japanese, and also the others, B51 or HLA region is causing the most significant finding. So B51 is definitely much stronger associated with Behçet's disease than all other non-HLA polymorphisms. But B51 is also quite frequent in healthy populations. If you look at the frequency of B51 in different healthy populations, it is ranging between 12 to 29. Therefore, HLA-B51 is not very useful in the diagnosis of HS disease, especially in countries where B51 is quite prevalent. And also, if you look at the different disease phenotypes, different clusters, depending on the most prominent features of the disease, such as mucocutaneous, arthritis, ocular, neurologic, or GI involvement. This is the Japanese study showing 5 clusters. In Turkish studies, there is also a vascular cluster. B51 is associated with the classical features of HS disease, but it is not as prominent as other manifestations in patients with GI involvement. So GI involvement is probably a different subset, and it is overlapping greatly with Crohn's disease. And after the identification of B51, many investigators, including ours group, focused on the identification of any other new gene, a novel gene, in linkage disequilibrium with B51. And even one of the JIVA studies suggested that it is probably not B51, but some polymorphisms in between HLA-B locus and MIC-A. However, Mike Umbrello and my other colleagues from the NIH, when he investigated the Turkish cohort, he clearly showed that if you delete B51 from the same haplotype, the distribution of this haplotype in patients and controls is almost similar, around 4%. But if you add B51 to the same haplotype, it shows a dramatic difference with an odds ratio around 3. So B51 is the essential element in this haplotype. We cannot, of course, exclude the contribution of other neighboring genes or polymorphisms, but without B51, it's nearly similar between patients and controls. If B51 itself is responsible for the susceptibility to HS disease, there are at least 3 options to explain the immunologic basis of B51 association. And the first one is, of course, presentation of certain peptides to cytotoxic T cells, because HLA-B51 is a class 1 molecule, and its main function is presenting intracellular peptides to the T cells, cytotoxic T cells. But so far, we do not have any specific peptide which could be presented only by B51. The other option is, of course, as an HLA class 1 molecule, the W4 epitope may interact with receptors expressed on NK cells, cytotoxic T cells, or gamma delta T cells, which may activate both innate and adaptive immune responses. We and others, especially our British colleagues, investigated different KIR alleles interacting with BW4 epitope, and we could not actually identify any significant association to explain this strong association of B51 with HS disease. There are some findings suggesting an increased activating receptor expression or interaction in HS disease, but these interactions are not strong enough. And the third option is about the folding properties of this HLA class 1 molecule. It is a slow folding molecule, and depending on the peptides presented on this HLA class 1 molecule, there may be folding problems, and this unfolded protein response may activate endoplasmic reticulum, and this ER stress is leading to activation of innate immunity or autoinflammatory response. But for the adaptive immunity and folding problems, we need peptides or peptide interactions. And our Immunochip study with NIH by Yohei Krino and colleagues who investigated Turkish and Japanese cohort revealed a strong association with ERAP1, endoplasmic reticulum aminopeptidase 1, only in those carrying HLA-B51. So if you are B51 positive, and if you're carrying ERAP1 haplotype homozygosely, well, that's actually increasing the risk enormously. And B51, ERAP1 is actually a critical enzyme in processing certain intracellular peptides. So we have different intracellular peptides deriving from our own proteins or intracellular pathogens within the cytosol, and proteasome and immunoproteasomes are digesting these peptides, and these smaller peptides are entering into the endoplasmic reticulum, and within endoplasmic reticulum, ERAP1 and ERAP2 are digesting them to be able to have certain length peptides around 8 to 11 amino acid length to be able to present them on HLA-B51 molecule. And we, Takeuchi and colleagues, along with Elaine Remmers from the NIH group, identified at least 10 different ERAP1 haplotypes, and haplotype 10 has been found to be strongly associated with Behçet's disease. If you are carrying homozygous ERAP1 haplotype plus B51, the risk of Behçet's disease is increasing 11 times. So that is actually the real explanation for B51. So B51 itself is not important. You have to have some additional factors defining the peptides presented onto it. And haplotype 10 has some properties, which is explaining why B51 and ERAP1 combination is causing the disease. This enzyme, when it's haplotype 10, has a lower enzymatic activity and producing a peptidome with a lower affinity for B51. So it's producing mainly more alanine for the B pocket in the second position, and compared to proline, more alanine is actually has a lower affinity for B51. Therefore, this is the main reason. But in addition to HLA-B51, both Turkish and Japanese GWAS studies show that within the HLA class 1 region, there is an independent weaker association. And this weaker association is in the HLA-A region, and this association has been confirmed in detailed analysis that it is independent from HLA-B51. And for the analysis of other HLA-A and B alleles, either using ascertained HLA-B antigens or imputed two-digit classical HLA antigens, and Mike Ombrello showed some additional risk alleles with weaker associations, such as HLA-B15, 27, 57, and also HLA-A26, and also some protective alleles, such as HLA-B49 and HLA-A03. And this is really quite interesting because carrying B51 itself is not enough. If the second HLA-B allele is HLA-B49, your odds ratio is going down to 0.6, so which is actually protecting you from HLA-B51 associated disease risk. Or if you are carrying just B15 and B49, the risk is actually much lower. The protective alleles are again diminishing the effects of these risk alleles, especially HLA-B51. And we know that HLA-A26 has been reported before from Japan as an independently associated susceptibility factor for Behçet's disease, especially for uveitis. And it is independent from HLA-B51, and presence of HLA-A26, which is more prevalent in Japan compared to Turkey, is increasing the risk of ocular involvement, especially for retinal choroiditis or iridocyclitis. And all of these HLA alleles, especially the associated ones, are actually having some changes in critical positions binding the peptides. So these positions include for HLA-B alleles 67, 97, 152, 116, and they all are interacting with the peptides. And the critical positions are including the B pocket, which is binding the second amino acid in the peptide, and also the carboxy terminal. But if you look at the B pocket of B51, which is mainly preferring proline compared to alanine, for A26 it's V or T, but the protective HLA-49 allele is receiving E, an acidic amino acid, for the B pocket, and it's different for A3. So peptides, especially the second position, B pocket binding peptides, are critical, and EROP1 is determining this second position. And when we come to the non-HLA alleles, GWAS studies revealed several non-HLA genetic polymorphisms contributing to VHS susceptibility, and they are mainly affecting the immunity against different pathogens. And also they are influencing the strength or polarity of our adaptive and innate immune responses, which includes IL-23R, IL-10, IL-1 locus, CCR1, IL-12A, and RIP kinase, KLRC4, LAC1, IRF8, and PTPN1, and also homozygous FUT2 or FUT2. And when we investigate these non-HLA associations in total, they have several shared features with other inflammatory disorders, especially the shared inflammatory pathways is quite prominent compared to spondyloarthritis and especially for Crohn's disease. So HLA, non-HLA associations are overlapping greatly with spondyloarthritis, especially with Crohn's disease, and clinically in certain parts of the world, it's really most challenging conditions to differentiate VHS disease from Crohn's disease. There is also an interesting similarity with leprosy tendency, although we know that it's probably not a tendency for infection, but is associated with an immune response against different pathogens. And leprosy patients are developing erythema nodosum, arthritis, and uveitis in response to microbacterial challenge. So the similar inflammatory response is also seen in VHS patients to different microbial triggers, but these immune responses are again showing some similarities. And a recent GWAS study investigating a total of 9,444 patients from 7 different populations, including Turkish, Spanish, Italian, Korean, Tunisian, Japanese, and Western European populations, identified 2 additional genetic polymorphisms in interferon gamma receptor 1 and also an intergenic region between LN carot and DKK1. And we still don't know the significance of these new associations, but this interferon gamma receptor 1, this is probably one of the promising ones. And the rare variant analysis also revealed some associations with TLR4, NOT2, and MEFB, which are also shared polymorphisms with Crohn's disease. But if you look at the direction of associations, the alleles or polymorphisms protective for BD are actually risk alleles for Crohn's disease in TLR4, NOT2, and MEFB. So compared to Crohn's disease, exaggerated inflammatory response against certain microbial triggers are causing VHS disease, but the effective clearance of certain microbial antigens are responsible for Crohn's disease. And lastly, there are some monogenic mimics of VHS disease as well. So investigation of certain families with some features mimicking VHS disease first identified an association with A20. Now we call it haplotype insufficiency for A20. And this condition first suggested as a monogenic VHS disease, but if you look deeply into the clinical manifestations, this HA20 patients has more severe ocular disease causing necrotizing inflammation and choroiditis, which is unusual for VHS disease. And also they have some autoimmune features with autoantibodies, and the disease is starting much early, it's dominantly inherited, and after ulcers are scarring. But it's not only for A20, mevalonate kinase disease, or several other genes within the innate immunity, including the MEFE, TNF receptor, STAT1, WDR1, or DADA2, or NEMO, REAL-A, GM-CSF are associated with some manifestations overlapping with VHS disease. And most of them are actually interacting with NF-kappa B pathway. So A20, NEMO, REAL-A are controlling the NF-kappa B activation, and uncontrolled NF-kappa B stimulation is resulting in a clinical picture resembling VHS disease. At the other end of the spectrum, for the more common manifestations, recurrent after stomatitis, those simple after stomatitis, also show great similarity for non-HLA polymorphisms. In canker sores, which is probably the most common inflammatory condition which can be seen in about 10% of healthy population, carrying polymorphisms in IL-12A, IL-10, and CCR1, which are again the findings we obtained in VHS disease, is increasing the risk for recurrent after ulcers. And in PFAPA patients, which is a condition frequently seen in children with oral ulcers and tonsillitis and cervical adenitis, again sharing the similar manifestations. But if you focus on HLA region is defining the phenotype. So only HS patients has strong HLA plus one HLA B51 association, and that one is defining the phenotype. So in conclusion, I have tried to summarize you the HLA and non-HLA genetic polymorphisms, and B51 is still the strongest genetic factor defining the phenotype of the disease, and it's showing an interaction, epistatic interaction with ERAP1. So the combination of haplotype 10 and B51 is the real association. And for the non-HLA genetic polymorphisms, they are usually defining our capacity to sense and process different pathogens, different danger-associated signals, and also they are affecting the polarity and also the strength of inflammatory response, mainly activating innate immunity and cytotoxic T-cell response, Th1, Th17 polarization, and activation of endothelial cells. So I'd like to acknowledge the contributions of my colleagues from ophthalmology, especially Iknur Çağatürk'ün, Mary Oray, and from Department of Neurology and Genetics, and also the contributions from Cerrahpaşa Medical School, NIH, Lancaster, and Remmers, and other colleagues from Japan and other countries. Thank you very much for your attention.
Thank you very much, Ahmed, for a very illustrative talk. We all learned a lot from it. And now we move on to omics, which is both microbiomics and metagenomics. And we have today with us Dr. Pizeng Yan, who is going to talk about yet another complex topic. So, Pizeng, may I request you to please start sharing your screen?
Yeah. Okay.
Yes.
Distinguished Chairman, ladies and gentlemen, it's a great honor for me to present our study on microbiomic and metagenomics in Behçet's disease. As you know, Behçet's disease is one of chronic systemic autoinflammatory disease, is characterized by oral ulceration, recurrent uveitis, multiform inscillation, and genital ulceration. It has been shown there is a high prevalence in the countries along the Asian Silk Road, such as Turkey, Japan, and China. The mechanisms involved in Behçet's disease are still not clearly understood. It has been shown an immune response in individuals with risk gene background is responsible for BD pathogenesis. Innate and adaptive immune response play a role in the development of this disease. Both Th1 and Th17 cells are involved. Recent studies show gut microbiome contribute to the development of several inflammatory or autoimmune disease. For instance, psoriatic arthritis, inflammatory bowel disease, multiple sclerosis, rheumatic arthritis, and etc. Recent studies show elimination of gut microbiome could inhibit EAO and EAE. However, the role of gut microbiome in BD is not clearly identified. We have done a series of studies to investigate whether there were change in the composition of the gut microbiome in Behçet disease to investigate the interaction of BD-associated gut microbiome, to investigate the potential function of the gut microbiome in Behçet disease, and finally, to investigate whether and if any, how the feces from active Behçet patient influence the development of EAO. The first part of our study was to investigate whether there were changes in the composition of the gut microbiome in BD patients. We collected sample from active BD patient and healthy control. The method involved in this study include metagenomic sequencing, MGS analysis, random forest classifier model. The results show at the final level, the dominant microbiome in BD patient and control were bacterial, that is, formicule, proteobacterial. The diversity of the gut microbiome was significantly higher in BD patients. The abundance of 97 genera and 23 species was significantly different between BD patient and healthy control. The most BD-enriched species belong to opportunistic pathogen, lactate-producing bacterial, and sulfate-reducing bacterial. The mostly normal-enriched species belong to methogen, butyrate-producing bacterial. Metagenomic species analysis show 11 MGS enriched and 2 MGS depleted in BD patients. BD enriched MGS were positively correlated with each other. The 13 MGS could distinguish BD patient from healthy control. The second part of our study were to investigate the interaction of BD-associated gut microbiome. The method used in this study include metagenomic sequencing and network analysis. The results show BD-enriched sulfate-reducing bacterial and lactate-producing bacterial were positively correlated with each other. Control-enriched butyrate-producing bacterial and methogen were positively correlated with each other. The BD-enriched sulfate-reducing bacterial were negatively correlated with control-enriched butyrate-producing bacterial and methogen. The third part of our study were to investigate the potential function of the gut microbiome in BD patients. The method used in this study include KEGG analysis and EGG-NOG analysis. The results show 25 KO and 13 OG in BD patients were significantly different from those in the control. Several BD-enriched KO or OG markers could belong to oxidation reduction process. One BD depleted KO belong to less of them. At the module or pathway level, BD patients were enriched in capsular polysaccharide transport system, type 3 and type 4 secretion system. The last part of our study was to investigate whether and how the features from active BD patient influence the development of EAO. we first transplant feces from active patient and control, and then evaluate its influence on the development of EAO and differentiation of Th1 and Th17 cells. The results show that mice transplanted with BD feces had severe EAO activity clinically and pathologically. We also found the dysfunction of the intestinal barrier in mice receiving transplantation of BD patients' feet. We found a decreased expression of 3 tight junction protein, including claudin 1, 4, and occludin in the colon tissue from the BD recipient mice. We also found an increased LPS level in these mice. The MRI expression of CD4 positive T cell changed significantly in BD recipient mice. There are totally 1,378 gene increase, 276 gene decrease. Decrease analysis show MRI expression of CD4 positive cell mostly enriched in antigen processing and presentation. Gold enrichment analysis show MRI mostly enriched in innate immune response, positive regulation of immune response T cell activation, lymphocyte differentiation, and response to bacteria. We also did a study on the neutrophil activation and evaluated its effect on Th1 and Th17 differentiation. In BD recipient mice, we found the increase NE-MPO expression by neutrophil and the cell from mesenteric lymph node. Th1 and Th17 cell differentiation was promoted when culture with the BD recipient neutrophil. So this result show gut microbiome in BD patient may induce Th1 and Th17 cell differentiation in mesenteric lymph node and spleen cells. Discussion and summary. There was a significant change in the gut microbiome in active BD patient. Overgrowth of some opportunistic pathogen may lead to decrease of mycogen and butyrate producing bacteria. Transplantation of feces of active BD patient into mice could increase EAO activity, decrease the expression of 3 tight junction protein in the colon tissue of the mice. Appreciate the expression of a gene mainly involved in the immune response Th1 and Th17 cell differentiation. Collectively, our results show this abnormality in the gut microbiome may cause damage to the intestine epithelial barrier and facilitate effect molecule of pathogen-associated molecule pattern to invade the intestinal epithelial cell, and in turn induce series of inflammatory reaction. The result stated above have been published in Microbiome and Frontier in Cell Development and Biology. I would like to thank my colleagues for their great contribution in this study. So thank you for your attention. Thank you.
Thank you very much, Biseng. That was really a very interesting topic. for all of us. Thank you. May I request you to please stop sharing the screen so that we can allow the next person, who is Ahmed Abu El Esrar. And Ahmed is going to talk to us about local cytokine expression, biomarkers that will help in the differential diagnosis, monitoring, as well as would be the drug targets. Over to you, Ahmed.
Thank you, Vishali. I would like to thank Manfred and Vishali for organizing these sessions. And because I believe these are very educational sessions. My presentation today will be based on what we previously published on cytokines and chemokines in the aqueous humor of patients with different uveitic entities. I would like to thank my colleagues from University of Leuven, Riga Institute, from the left to Professor Jovan Dama, Professor Sofistrar, Professor Kali Gabous, and Professor Abdonaka. In fact, many of the cytokines and chemokines that I am discussing today are discovered in their laboratories. As you know, endogenous uveitis is a clinically heterogeneous group of blinding intraocular inflammatory disease and is frequently occurring in association with systemic inflammatory diseases such as HLB27, associated uveitis, Behçet disease, Vogt-Koenig-Harada disease, and sarcoidosis. And as we know, there are several clinical phenotypes in patients with uveitis, and which suggests that each of these clinical phenotype, might have specific immunopathogenic mechanisms. This is, for example, the phenotype of HLB27 associated uveitis with Fibonacci axon in two chamber. And this is a phenotype of Behçet disease with hypopyon, vitritis, retinitis, and diffuse leakage on fluorescein angiography. And the phenotype of Vogt-Koenig-Harada disease with hyperemia of the optic nerve head, oxidative retinal detachment, the typical fundus fluorescein angiography findings, the typical ICG showing many choroidal granulomas, and this is a phenotype of chronic recurrent Vogt-Koenig-Harada disease with granuloma two-segment inflammation and sunset glofundus. This is a phenotype of sarcoidosis with granuloma sclerotic precipitates. So you can see that we have different clinical phenotypes, and we know that cytokines and chemokines control inflammation and have important roles in the pathology of endogenous uveitis and are representing major targets for clinical intervention. The most famous example is biologics that target human growth factor alpha, which are used routinely to treat patients with Behçet disease. Another biologic that we are using also is tocilizumab that target anti-interleukin 6 receptor antibody, which can be effective in resistant case of uveitis. So for many years, we had the belief that if we characterize the specific cytokines and chemokines in each uveitic entity, this can serve two purposes. First, to identify novel biomarkers for each disease, and second, to identify novel therapeutic targets. So we started with cytokines. So interleukin-1 beta, IL-4, IL-12, IL-21, IL-22, IL-23 were not detected or detected at very low levels, suggesting that these cytokines cannot be used for as therapeutic targets. Then interferon gamma, which is a marker for T helper 1 lymphocytes, was significantly upregulated in all patients. And then we analyze the patients separately. We find that patients with Behçet disease had the highest levels of interferon gamma compared to HLB27, uveitis, and VKH disease, suggesting that the T helper 1 immune response, inflammatory response, is more potent in patients with Behçet disease. Then comes the very famous tumor necrosis factor alpha, which is a pro-inflammatory cytokine. It was upregulated in the aqueous humor of all patients. And when we analyze the patients separately, tumor necrosis factor alpha levels were highest among patients with Behçet disease, which can explain why patients with Behçet disease respond very quickly to anti-tumor necrosis factor alpha agents. This is an example of a patient with very aggressive Beheet disease, severe vitritis, multiple patches of retinitis, typical fluorescein angiography, and after infliximab, there is dramatic improvement. And I'm still following up the patient, and the vision is still kept at 20/20 on both eyes. So all of us know that anti-TNF alpha agents are very potent in patients with Beheet disease. Now looking at interleukin-17, which is a marker of T helper 17 cells, which are also involved in autoimmune disorders. They are elevated in IL-17, elevated in all patients, and again, the levels are highest in Beheet disease, suggesting that both T helper 17 and T helper 1 subsets are involved in endogenous uveitis. IL-6, which is another important pro-inflammatory cytokines, was elevated, but the levels were highest again in HLB27 and Beheet disease, compared, of course, to controls, VKH disease, sarcoidosis, and idiopathic granulomatous uveitis, which suggests that IL-6 might be heavily involved in non-granulomatous uveitis, such as HLB27 and Beheet disease, and suggesting that tocilizumab, which is humanized antibody that blocks interleukin-6 receptor, might be useful for HLB27 uveitis and Beheet disease. Then we looked at the IL-10 family of cytokines, and this include a family of IL-10, IL-19, IL-20, IL-22, IL-26, IL-28A, and IL-29. Among this family, only interleukin-19 levels were significantly higher in aqueous humor samples of patients than in control. But it was very surprising that IL-10, as you know, IL-10 is a cytokine that down-regulate inflammation. The levels of IL-10 were least in patients with Beheet disease. That means that protective cytokines that down-regulate inflammation were least in patients with Beheet disease. IL-19 levels were significantly higher in HLEB27-associated uveitis compared to other uveitic entities. You can see here that the levels in HLEB27 were much higher than that in Beheet, sarcoidosis, and VKH, suggesting that IL-19 might be a biomarker for HLEB27 uveitis. IL-19 is produced mainly by monocytes, and it can induce in monocytes the production of TNF-alpha and IL-6, indicating its a pro-inflammatory nature. Then we looked at the hematopoietic family of cytokines and the tumor necrosis factor superfamily. Among the hematopoietic family, IL-11 was significantly higher again in Beheet disease. But what was interesting that among the tumor necrosis factor superfamily of cytokines, April, BAF, and DTWIC are controlling the function of B cells. They even induce B cell activation, proliferation, survival, autoantibody formation. And the levels of this B cell cytokines were significantly highest in patients with VKH disease, suggesting this another data to support that B cells are involved in Beheet disease. But IL-11 was highest in patients with HLB27 uveitis. Then we looked at soluble cytokine receptors. Again, there are a lot of data, but the most important data here is that the soluble CD30, which is produced by CD30 positive T lymphocytes, were highest in patients with forked Hennig-Hardy disease, suggesting that CD30 positive T cells might be involved in the regulation of inflammation in VKH disease. Then we looked at chemokines. Chemokines are belonging to three groups: CXCC, CXCC, and CX3C. Among the CXCC chemokines, there are a big group called neutrophil chemoattractants. We know that the chemokine receptor CXCR1 and CXCR2 are expressed on neutrophils. And the interaction between these two receptors and the CXCC chemokines, their ligands, will induce neutrophil invasion and activation. And this pathway is induced by tumor necrosis factor alpha or IL-1 beta. So we looked at these cytokines, and again, it was very surprising that the levels, first of all, the three most important neutrophil chemoattractants, CXCL1, CXCL5, and CXCL8. And you will notice that the levels were highest for HLB27 and Behçet disease compared to VKH and sarcoidosis, which means that neutrophil chemoattractants are playing a major role in the pathogenesis of HLB27 and Behçet disease. Then if we compare non-granulomatous uveitis, the difference is very clear. So these observations consistent with previous reports showing that neutrophil infiltration and activation are important in Behçet disease and HLB27. Therefore, targeting the receptors of these chemokines XCR1 and CXCR2 on neutrophils might be a good option for the treatment of Behçet disease and HLB27 associated uveitis. And in fact, there are direct clinical and clinical studies that demonstrated the efficacy of blocking CXCR1 and CXCR2 receptors on neutrophils to reduce neutrophil activation and recruitment and attenuate neutrophil-mediated inflammation. Then another group of CXC chemokines that act predominantly on T helper 1 lymphocytes. So there are three members, and they act mainly on one receptor, CXCR3 on T helper cells. These are MIG, IP10, and ITAC. Among these three chemokines, IP10 was the highest, indicating that IP10 would be the most important T helper 1 chemoattractant in ocular inflammation. And again, the levels were highest in patients with Behçet and HLB27 uveitis. This finding suggests that blocking CXCR3, which is the receptor for IP10, might be useful in patients with Behçet and HLB27 uveitis. Then we looked at a group of chemokines called lymphoid chemokines. As we know that currently it has been shown by many studies that B lymphocytes play an important role in pathogenesis of autoimmune diseases such as rheumatoid arthritis, Sjogren's syndrome, and many others. In all these diseases, there is formation of what we call it ectopic lymphoid aggregates that contain B lymphocytes. And the formation of this lymphoid aggregate depends on four chemokines. Most important of them is B cell chemoattractant because these lymphoid aggregates contain a large number of B lymphocytes. So the B cell chemoattractant is also called CXCL13, which act on one receptor, CXCR5 expressed on B cells. We looked at this because we had impression that B lymphocytes might be involved in pathogenesis of autoimmune uveitis. Among the four lymphoid chemokines, only two were detected. The SDF1 or CXCL12, but the levels did not vary significantly between the uveitic entities and the levels were low. But what was surprising here is the CXCL13, the B cell chemoattractant. It is actually stood as a biomarker for VKH. So among this, the four groups of uveitis that we studied, CXCL13 were the highest. And we proved this in two sets of samples using two different multiplex assays. So what does this mean? It means that B cells might be heavily involved in the pathogenesis of patients with Behçet disease, of Vogt-Koyanagi-Harada disease. And this was consistent with one of our previous studies in which we analyzed the inflammatory cell infiltration in the choroid of patients with sympathetic ophthalmia, which is a disease very close to VKH. This is marker for T lymphocytes, and this marker for B lymphocytes. In fact, you can see that the number of B lymphocytes is more compared to the number of T lymphocytes. And this data, the cytokine data, the chemokine data, the immunohistochemical data suggests that B lymphocytes are mostly involved in patients with Vogt-Koyanagi-Harada disease. Therefore, we started a study in which we treated patients with resistant Vogt-Koenig-Harada disease, uveitis, mainly chronic recurrent disease, with B-cell depleting therapy using rituximab, which is an antibody against CD20. And these data were already published, and we could see that rituximab was extremely useful in patients with chronic recurrent Vogt-Koenig-Harada disease. This is before and after the patient had cataract surgery and the eye is completely quiet. So B-cell depletion therapy was very effective in patients with refractory uveitis associated with chronic recurrent Vogt-Koenig-Harada disease. So based on this, we can say that granulomatous inflammation like VKH is B lymphocyte driven because of the B-cell chemoattractants, XCL13, and non-granulomatous uveitis such as Beheet and HLB27 is T helper 1 lymphocyte and neutrophil driven. We looked also at the CC chemokines. CC chemokines, these are the group of chemokines acting only or mostly on mononuclear cells. And among the CC chemokines, CCL8, CCL13, and CCL20 was called also MEB3A, were the most strongly upregulated chemokines. But when we looked at the distribution in different uveitic entities, the levels were always highest among patients with HLB27, followed by Beheet disease. You will see always similarity between Beheet disease and HLB27 associated uveitis. In fact, for CCL20, we were very impressed with very high levels in patients with HLB27 compared to other uveitic entities. And we proved this in 3 sets of samples using 3 different multiplex assays. So the data suggests that immune responses mediated by CCL8, CCL13, and CCL20 appear to be more potent in non-granulous uveitis, particularly in HLB27 associated uveitis. So in conclusion, our findings suggest that the intraocular levels of cytokines and chemokines differ depending on the cause of uveitis. Both T helper 17 and T helper 1 cells are implicated in the immunopathogenesis of endogenous uveitis, as we detected elevated levels of both T helper 17 and T helper 1 associated cytokines. However, it remains to be investigated how T helper 17 and T helper 1 cells interact among themselves and with the other regulatory effector T cell subsets. We showed that IL-6 driven immune responses are more potent in Beheet disease and HLB27 associated uveitis. Inflammation mediated by neutrophils and T helper 1 cells appear to be more potent in non-granulomatous uveitis associated with Beheet disease and HLB27 related inflammation compared to granulomatous uveitis associated with sarcoidosis and VKH disease. In the ocular inflammatory microenvironment of patients with endogenous uveitis, CCL20 might serve as a biomarker of inflammation in HLB27 associated uveitis. The B-cell chemoattractant CXCL13 might serve as a biomarker of uveitis associated with VKH disease. Therefore, B lymphocytes may contribute to the inflammatory process in VKH, and we showed this by our trial of using rituximab to control inflammation in patients with resistant uveitis associated with VKH disease. Of the members of the IL-10 family of cytokines, IL-19 demonstrated the highest expression in endogenous uveitis, particularly in HLB27 uveitis. IL-11 also was highest in HLB27 uveitis, and soluble CD30 levels were highest in VKH disease, suggesting that CD30 positive T cells might contribute to the inflammatory process in granulomatous uveitis, particularly in VKH disease. So my main conclusion here is that analysis of the aqueous humor from patients with specific uveitic entities can help us to optimize the selection of biologic therapy. I would like to add here that in patients with refractory uveitis associated with chronic recurrent VKH disease, we tried in the past anti-TNF alpha agents, especially infliximab, without any success. However, these patients, they showed good response to B-cell depleting therapy with rituximab. Thank you very much for your attention.
Thank you very much, Ahmed, for giving us insight into how we are going to practice personalized medicine in future. Very, very interesting. And now we move on to the clinical aspects of the disease. And we have none other than Ilknur Tugul talking to us about characteristic feature and clinical diagnosis in Beheet's disease. Over to you, Ilknur.
Well, I'm trying to share my slides. I'm having some difficulties this morning. Let me know if you can see it.
Yes,
can you?
Well, yes. Can you go to the slideshow?
Sure.
There you go.
Okay, thank you. Thank you very much, Vishali. So in the next 20 minutes, I will try to describe the characteristic features of Beheet uveitis, clinical features, and try to outline how we make a diagnosis of Beheet disease uveitis. This is my disclosure. Well, we have listened to beautiful talks from our previous speakers, showing, significant findings as genetic markers, biomarkers, cytokines, but still there is no specific diagnostic test for Beheet disease, no lab test. And we still use these clinical criteria sets for the diagnosis and classification of Beheet disease. And in all these criteria sets, uveitis is one of the major criteria. However, uveitis in Beheet has been non-specifically described as in the international study group criteria. You see here anterior uveitis, posterior uveitis, cells in vitreous, retinal vasculitis, all non-specific descriptions. Also in the more recent international criteria set, the same is true. In the new classification criteria for Beheet disease uveitis published by the Sun Working Group, a compatible uveitic syndrome was defined as anterior uveitis, anterior and intermediate uveitis, or posterior or panuveitis with retinal vasculitis and or focal retinal infiltrates, and a diagnosis of Beheet disease using ISG criteria is required for the patient to be classified as Beheet disease uveitis. And as you can see here, focal retinal infiltrates seem to be the only additional descriptive feature in the definition of eye lesions in Beheet disease here again. Exclusions are syphilis and sarcoid. And more importantly, choroiditis was defined as an incompatible feature for Beheet uveitis in this new criteria set. Well, actually, Beheet uveitis is a distinct entity. Extraocular manifestations confirm the diagnosis, but the absence of extraocular manifestations does not rule out a clinical diagnosis of Beheet uveitis. And indeed, uveitis is the initial manifestation in up to 20% of our patients. There are also Beheet patients with non-Beheet uveitis by coincidence. A typical Beheet patient with uveitis is a young adult. Onset of disease before 20 years of age or after 50 years of age is uncommon. Male to female ratio is 2:1 in our patient population. It is mostly bilateral, always non-granulomatous, and panuveitis with retinal vasculitis is a typical or classical form of involvement. However, isolated anterior uveitis can also be seen, mostly in women with only mucocutaneous manifestations. The most characteristic features of this entity are the recurrent nature first. Recurrent symptomatic acute inflammatory attacks are seen, which tend to spontaneously resolve. I mean, the attack symptoms and signs tend to resolve even without treatment, and persistent breakdown of the blood-retina barrier is also a distinct characteristic feature in Behçet uveitis. Here I show two graphs from a chapter that I wrote with late Professor Yılmaz Özyazgan, showing changes in visual acuity, the sudden drop in visual acuity with each activation in these cases who had been treated with conventional immunosuppressive agents, and the recovery of vision after each attack. A spontaneous resolution of acute inflammatory signs is true for all manifestations of Behçet's disease, also extraocular manifestations of the disease, and this has been long known. This was a pregnant patient who refused any treatment other than topical steroid, and we could observe the resolution, spontaneous resolution of these acute inflammatory lesions in the retina within a week in this patient. Even in the absence of any demographic information or any information on the course of the disease, experienced uveitis specialists can recognize Behçet uveitis. We have proved this some years ago. We collected clinical photographs from Behçet patients and also from patients with non-Behçet uveitis, put these photographs in random order and sent them out to uveitis specialists around the country in Turkey, and up to 81% of the photographs could be correctly identified as Behçet or non-Behçet by experienced Turkish uveitis specialists. With all this knowledge and experience, we have developed an algorithm, a guide to diagnosis, if you will, based on a combination of ocular features for the diagnosis of Behçet disease uveitis. This was a multi-center, multinational retrospective study, and the most important clues in patients with vitritis that lead to the diagnosis of Behçet uveitis were found to be absence of granulomatous anterior uveitis or choroiditis, most importantly, and presence of superficial retinal infiltrates or their sequelae, namely retinal nerve fiber layer defects, signs of occlusive vasculitis, active or sequelae, and diffuse retinal capillary leakage on fluorescein angiography. Anterior segment inflammation in Behçet is always non-granulomatous, and it may resemble HLA-B27 uveitis. Ahmet Asrar already showed the similarities in cytokine expression. The sudden onset of uveitis attacks bear similarity. However, in Behçet, severe anterior segment inflammation is almost always associated with panuveitis, whereas in B27 it is an anterior uveitic entity. Around 20% of cases may have diffuse vitritis, but they never develop occlusive vasculitis, retinal infiltrates, etc. Other signs characteristic of Behçet disease. Well, Behçet patients may present with bilateral simultaneous uveitis attacks, but B27 patients typically develop alternating unilateral uveitis attacks. In Behçet, ciliary injection may be absent or disproportionately mild, even in an eye with a hypopyon, whereas in B27 there is a marked ciliary injection. Behçet uveitis is rarely fibrinous, B27 frequently fibrinous, and therefore in Behçet we see a shifting hypopyon with a smooth layer. In B27, sticky hypopyon is a common feature. And most importantly, response to topical treatment is different. In Behçet, we see a very rapid response to topical therapy, whereas in B27 patients, after even starting hourly potent topical steroids, the patient may come back the next day or 2 days later with more severe inflammation, even with a new hypopyon, and may require more aggressive treatment, and we never see that in Behçet. Diffuse vitritis is a constant feature of a posterior segment inflammation in Behçet patients, may resemble intermediate, idiopathic intermediate uveitis during the course of the disease, but in Behçet, diffuse vitreous haze has an acute onset and it is recurrent, whereas in intermediate uveitis, there is a chronic progressive haze. In Beheet, again, tendency to resolve and tendency to worsen in intermediate uveitis without treatment. And more distinctively, we see the development, appearance of these inferior pearl-like precipitates during the resolution of vitreous haze several days after the onset of a diffuse vitritis attack. And these are seen usually in a linear pattern. They seem to be sitting on the surface of the retina. They are much smaller than snowballs that are seen in intermediate uveitis that are mostly located in the inferior vitreous, but they may also be seen in the anterior or posterior vitreous, and they are much larger, and they are in the vitreous in idiopathic intermediate uveitis. Superficial retinal infiltrates are the most frequently seen acute inflammatory lesions in the back of the eye in Beheet patients. They may appear in any number, size, or location. There are usually retinal hemorrhages associated with these infiltrates, but the most characteristic feature, distinguishing feature, is the transient nature of these infiltrates in Beheet, and these are recurrent. They may appear at each attack. On OCT, these superficial infiltrates appear as focal hyperreflective retinal thickening with smudging, especially of inner retinal layers, with shadowing, but there is no focal choroidal thickening beneath these infiltrates, and there is no chorioretinal scarring after the resolution of these infiltrates, but one may see focal inner retinal atrophy, indentation, and altered plexiform layer elevation. It seems like the retina is pinched at that spot, and we see a secondary development of retinal nerve fiber layer when these lesions are located at the posterior pole, and one may find a corresponding scotoma on visual field. OCT finding of these sequelae, outer plexiform layer elevations, and this focal retinal atrophy is quite helpful in differentiating Beheet uveitis from intermediate uveitis, say in patients who present with diffuse vitritis, because angiography may not be really helpful, may reveal similar features in Beheet and idiopathic intermediate uveitis. Such retinal infiltrates are typically also seen in infectious entities such as ocular bartonellosis, rickettsiosis, or post-fever retinitis, mostly reported from India. Fluorescein angiography is, I believe, the most helpful diagnostic or imaging modality, as fluorescein angiography in Beheet will show capillary leakage, even extensive leakage in Beheet, whereas in infectious retinal infiltrates, there's a target-like pattern as shown here. Branch retinal vein occlusion in Beheet, branch retinal artery occlusion in these infectious retinal infiltrates is typically seen. And as I said before, resolution of these infiltrates in Beheet is within days, but resolution may take several weeks in infectious infiltrates. Larger lesions in Beheet of necrotizing retinitis may resemble, for example, toxoplasmosis, but this is retinitis, and we don't see any visible scarring, but retinal atrophy in the wake of such lesions in Beheet, whereas in toxoplasmosis, which is a retinal choroiditis, we see scarring after the resolution of such lesions, and during the acute phase, you can see the OCT reveals different features, although there's diffuse retinal hyperreflective thickening in both entities in toxo, we see this fusiform thickening of the underlying choroid. Severe Beheet attacks may resemble severe serious infectious retinitis, such as that we see in syphilis or viral necrotizing herpetic retinopathies. But in Behçet, there is no specific pattern. There is diffuse vitritis, which is most severe at the onset of the acute episode. We see retinal hemorrhages, widespread. They can be occlusive arteriolitis is a prominent feature, even a diagnostic feature in viral necrotizing retinopathies, but is not a prominent feature in Behçet. And in Behçet, lesions do not progress or coalesce. Even without treatment, there is a tendency for resolution, as I said before, whereas without specific treatment in infectious retinitis, of course, we see progression, worsening of the clinical picture. Behçet neuroretinitis, which we used to call disc infiltrate before we started using OCT imaging, is more frequent than papillitis or ischemic optic neuropathy, which can also be seen in Behçet patients. This is typically unilateral. There may be other signs of posterior segment inflammation, such as retinal infiltrates or occlusive vasculitis, maybe recurrent, and shows a rapid resolution like most other lesions in Behçet patients and has a good visual prognosis. OCT typically shows a cloud or cap of hyperreflectivity overlying the disc, as shown also here. There's a rapid resolution in contrast to, for example, Bartonella neuroretinitis or toxoplasma neuroretinitis, which take longer to resolve and with sequelae. Occlusive retinal periphlebitis is mostly in the form of branch retinal vein occlusions. Rarely central retinal vein occlusion may be seen. I have never seen isolated arteriolar occlusion in Behçet, but it may accompany branch retinal vein occlusion, as seen in the middle photograph. At the onset of such occlusive episodes, there is a frosted branch type of diffuse sheathing and extensive retinal hemorrhages in the involved quadrant. It resembles hemorrhagic retinal vasculitis, and then later we see the development of ghost vessels on atrophic retina. There is always vitritis in Behçet occlusive episodes, and the development of these inferior precipitates after several days confirms the diagnosis of Behçet occlusive retinal vasculitis. It is recurrent, like other lesions, and when you look at the fundus, you can see the recurrent nature and the chronology of these occlusive episodes, which may result in profound macular ischemia and irreversible visual loss. However, MVE is quite a rare complication following these occlusive episodes in Behçet patients. We mostly see the development of shunt vessels, vascular rearrangements, and the occluded zone shows diffuse retinal atrophy. These are not laser spots. We do not routinely laser these cases. These are just window defects, and we see retinal atrophy here. So probably VEGF secretion or production is not an issue in most cases of Behçet occlusive vasculitis. In between attacks, there is clinical remission, which means no anterior chamber cells. There may be some residual vitreous cells, but no haze, and no active lesion in the fundus. You can see the similarities of these two clinical photographs, color photographs of these two cases. So it is only fluorescein angiography that distinguishes between complete remission, that is angiographic remission, and persistent subclinical inflammation, that means leakage, diffuse leakage, mostly in the form of fern-like capillary leakage. Therefore, fluorescein angiography is the gold standard in monitoring Behçet patients. Persistent retinal capillary leakage or fern-like leakage is associated with a high risk of cystoid macular edema, development of macular edema, high risk of disc neovascularization. In the majority of cases, you see diffuse leakage rather than extensive retinal non-perfusion when the eye has MVD. And most importantly, persistent leakage means that the eye is like a smoking volcano that may explode anytime. There is a high risk of a recurrent uveitis attack in eyes with persistent leakage. We have seen several examples of this. Even in advanced disease with extensive retinal atrophy, if there is any leakage, there is a high risk of a recurrent attack, as in the case of this patient. A hypopion attack occurred with the eye with persistent leakage, so it's not surprising these patients develop attacks. Therefore, we need to check FA before naming it end-stage burnt-out disease in patients with advanced damage. Here is an eye with optic atrophy, ghost vessels all around, and diffuse retinal atrophy. But there is some sign of leakage on fluorescein angiography. Such patients still require treatment, ongoing treatment. I would like to conclude with two recent cases I have seen. This was a 25-year-old man who had recurrent visual blurring. He was on treatment with azathioprine, and a tapering dose of oral steroids started elsewhere. He had no active sign of inflammation. Visual acuity was 20/20 in both eyes. And when I first saw him, I noticed this retinal nerve fiber layer defect inferiorly at the posterior pole in the right eye. Fluorescein angiography showed optic disc staining and peripheral leakage in both eyes, and it was OCT that confirmed the diagnosis of Beheet disease uveitis in this patient who did not fulfill any diagnostic criteria set. Here we can see the retinal pinching, the so-called pinching with the outer plexiform layer elevation, which you will find in Beheet patients. And this confirms that the patient had had an episode of retinal infiltrate here before I saw him. Here's another patient, a 40-year-old man who had been on high-dose oral steroid. Somebody started high-dose oral steroid more than 2 months ago, and he kept on taking this high dose because at each attempt he tried to reduce the steroid dose. He had a recurrent visual blurring, most recently in the left eye. His visual acuity was 20/20 in the right, 20/200 in the left eye, and both eyes had vitreous cells. And here I saw again this retinal nerve fiber layer defect, which is more readily seen on red-free imaging and confirmed by OCT. Blue autofluorescence doesn't help. Fluorescein angiography only showed some partial disc staining, no vascular or capillary leakage in that eye. In the left eye, he had some vitreous condensation concealing the nerve fiber layer defect, sort of. I could see this here, but OCT clearly showed these nerve fiber layer defects superiorly here and here. And fluorescein angiography showed disc staining, no vascular or capillary leakage, but obviously the patient had a previous episode of occlusive vasculitis in that eye, which we could see in peripheral fluorescein angiography, also on OCTA. So he had all these ocular features on multimodal imaging, even in the absence of diffuse capillary fern-like leakage in this patient who had been on high-dose steroids and who did not fulfill any of the diagnostic criteria sets. We could easily make a diagnosis of Beheet disease uveitis and started appropriate treatment in this patient. And this concludes my talk. Thank you very much for your attention.
Thank you very much, Elknur. Always a pleasure to listen to you. And now we move on to Dr. Hiroshi Kino, who is going to talk about imaging and outcome measures in Beheet's disease. And may I request all the speakers to please check Q&A box, because there are questions which we would like you to type answers. Over to you, Hiroshi.
I'd like to thank organizers Manfred and Bishari for providing me opportunity to present the imaging and outcome measure in the Beheet disease uveitis. So this is my final disclosure. Today, I'd like to talk about the multimodal imaging of the posterior segment in a Beheet Uveitis, including the fluorescein angiography, the OCT, and OCT angiography. And the second topic, I'd like to introduce the Beheet disease ocular inflammation score post-24. So I talk about the fluorescein angiography. So there are ocular findings in the Beheet disease and during the active inflammatory phase demonstrates the recurrent idiopathic retinal infiltrate, the diffuse vitreous opacity, and retinal hemorrhage. So the fluorescein angiography is a gold standard imaging to monitor and detect the vascular leakage in the Beheet Uveitis. So the fun-like diffuse capillary leakage is a characteristic findings in the Beheet Uveitis, and these findings has been observed not only during the active phase but also in the convalescent phase. And other FF findings are the staining of the retinal vessels and the CME. And previously, the number et al. Have demonstrated the frequency of ocular fluorescein angiography findings in the Beheet Uveitis. The frequency of the fun-like fluorescein leakage was 84%. And second, the hyperfluorescence of the optic disc was 71%. And the frequency of the non-palpation area was 7.7%. So recently, the ultra-wide field imaging system is widely used for the retinal choroidal diseases. The ultra-wide field fluorescein angiography allows the visualization of the peripheral vascular leakage and the non-palpation area in the Beheet Uveitis. So the several papers have shown the association between the fluorescein angiography findings and visual prognosis. You et al. Have demonstrated that the FF findings of the disc neovascularization and the macular window defects indicate the poor visual outcomes. And Kim et al. Have shown that the post-pole involved retinal vascular leakage, optic disc hyperfluorescence, and macular leakage are associated with the poor visual acuity. So previously, we have reported the effect of the infliximab on the vascular leakage on the fluorescein angiography at the set of the quiescent in the Beheet patients. As you can see, at baseline, the background diffuse vascular leakage in the posterior pole and the peripheral retina before infliximab therapy, and at 6 months after initiation of infliximab, the vascular leakage has been improved. So next, we conducted the semi-quantitative analysis of FA findings before and after initiation of infliximab. To assess the degree of the background vascular leakage, fluorescein angiography was performed prior to the initiation of infliximab therapy and at the end of year 1 at the time of clinical quiescence. The extent of the fluorescein vascular leakage was graded on a scale 0 to 3 for the peripheral retina and macular area and optic disc. The total vascular leakage score represents the sum of these three areas. So we compared the fluorescein angiography scores at baseline and on infliximab therapy. So in peripheral retina and total score, the FA score was significantly reduced at 12 months after initiation of infliximab treatment. So next, we examined the long-term efficacy of infliximab on the frequency of ocular attacks and the background vascular leakage. The frequency of ocular attacks in each patient reduced after starting infliximab treatment and remained low level in most patients over the 4 years. However, the blue allows indicate the patient 5 showed the trend toward rising frequency after 2 years. Similarly, the FA score in each patient was reduced on infliximab treatment. However, in patient 5, the FA score appeared to have increased at the end of 4 years. So Shirahama et al. Have investigated the relationship between the FL leakage after injection treatment and the relapse of ocular attacks in ocular Behçet disease patients. They classified the Behçet disease patients with refractory uveitis retinitis treated with infliximab into two groups. The group 1 includes the patients with ocular attacks after infliximab therapy, and group 2 includes the patients without ocular attacks after infliximab therapy. So they compared the FA score before and after the initiation of infliximab therapy between patients with ocular attacks and without ocular attacks. So they used the FA scoring system to quantify the FA findings. They used this FA score system has been reported by the angiography scoring for Uveitis working group. This scoring system includes the 9 angiographic signs. This table shows the FA score before and after the initiation of infliximab treatment in patients with and without ocular inflammatory attacks. So before the initiation of infliximab treatment, the FA score was comparable between the two groups. However, after the initiation of infliximab treatment, the FA score was significantly higher in group 1. So these findings suggest that the vascular leakage after infliximab treatment is biomarker to assess the activity of intraocular inflammation in patients with ocular Behçet disease. So recently, the Kim et al. Have investigated the utility of ultra-wide field fluorescein angiography for monitoring the therapeutic response to adalimumab in Behçet uveitis. So as you can see in both two patients, the vascular leakage in the posterior pole in the peripheral retina was reduced after initiation of adalimumab therapy. So they conducted the semi-quantitative analysis of FA findings using our FA scoring system reported by the angiography scoring for Uveitis working group. So this figure shows the changes of the FA score. As you can see, the FA scoring for each angiographic signs was reduced after starting the adalimumab treatment. So the next topic is OCT. So there are a transient retinal infiltrate. As you can see here, the commonly seen and during active phase. So the corresponding to this retinal infiltrates, the OCT shows the thickening of the inner layer in the retina. After 4 months in the remission phase, retinal infiltrate disappeared. However, the OCT shows the focal thinning in the inner layer of the retina. So these findings suggest that the localized retinal nerve fiber layers defects is a diagnostic indicator of the posterior pole involvement in early Behçet uveitis. So the Onal et al. Have investigated the diagnostic value of central foveal thickness, CFT, for predicting the presence of active intraocular inflammation in early Behçet uveitis. At a cutoff value of 275 micrometer or greater, diagnostic sensitivity and specificity of CFT for active Behçet disease was 89% and 72% respectively. So these findings suggest that CFT is a biomarker for predicting the active inflammation in early Behçet uveitis. There is a controversy regarding subfoveal corneal thickness in patients with Behçet disease uveitis. So Kim et al. Have demonstrated that the choroid is showing thickening in an active phase compared to that in the quiescent phase. So under the Ishikawa et al. Have demonstrated that the choroidal thickness was reduced after initiation of infliximab. On the other hand, the Koskan and colleagues have demonstrated that the choroid is thinner compared to that in a patient without ocular involvement. So Onal et al. Have investigated, Onal et al. Compared the choroidal stroma to choroidal vessel lumen ratio using binary image between eyes with active Behçet uveitis and control subject. So firstly, they compared the choroidal thickness between the Behçet disease patients and control subjects. They found that there was no significant difference regarding the choroidal thickness between two groups. However, the choroidal stroma to choroidal vessel-driven ratio was significantly higher in a Behçet uveitis. So these findings suggest that choroidal stroma expansion in eyes with active Behçet uveitis that could indicate the inflammatory infiltration in the choroid. The next topic is OCTA. OCTA allows the visualization of the blood flow in each retinal layers. So the Higher et al. Have demonstrated the OCTA findings in the Behçet uveitis. Upper left FA imaging shows the large hyperfluorescent non-perfusion areas, retinal vascular leakage, and collateral vessels in the macular area, infillotemporally. So the upper right FA findings show the magnified view of the red circle areas. Hyperfluorescence from leaky vessels masks the perifoveal non-perfusion areas. The left images, there is an OCTA of the superficial capillary plexus, visualize the delineated hypointense, the grayish areas of the retinal capillary non-perfusion area and telangiectasia. And the lower right image is the OCTA of the deep capillary plexus. The OCTA shows the grayish areas of the capillary non-perfusion, hyperperfusion areas. So they compared the OCTA findings and FA findings in the Behçet uveitis. They found that the frequency of the perifoveal areas of the capillary non-perfusion, hyperperfusion, and frequency of the perifoveal capillary abnormalities was significantly higher in the OCTA findings. So these findings suggest that utility of the OCTA allows the visualization and characterization of the perifoveal microvascular alterations. And some studies using OCT angiography showed that the both superficial capillary plexus and deep capillary plexus vessel density was significantly lower in eyes with Behçet disease, whereas the foveal vascular zone FZ is larger in eyes with Behçet disease. And recently, G et al. Have conducted the meta-analysis for the macular for emphasis superficial and deep vessel density between control and Behçet disease subjects. So these results indicate that the macular fold vessel density was significantly lower in patients with Behçet disease. Furthermore, they performed the meta-analysis for the FAZ superficial and deep in eyes with control and Behçet disease. So these findings suggest that the area of the superficial and deep FAZ was significantly larger in patients with Behçet disease. So next topic is a Behçet disease ocular inflammation score, BOS24. So the best Behçet disease ocular inflammation score, BOS24 scoring system was established to quantify the severity of individual ocular attacks. BOS24 consists of 6 parameters, including the anterior chamber cells, vitreous haze, peripheral retinal lesions, posterior region, foveal regions, and optic disc lesions. The total maximum score is 24 points. So this figure shows the frequency of ocular attacks and BOS24 6 months before and after initiation of infusion therapy. So as you can see, the frequency of ocular attacks was reduced after initiation of infliximab. And similarly, under the BOS24 6 months was also reduced after initiation of infliximab. And also, the authors have demonstrated the declining of BOS24 for individual ocular attack after initiation of infiltration treatment. So these results indicate that the BOS24 system allows the quantification of severity for individual ocular attack. So recent papers demonstrate the FA findings at the BOS24 are the prognostic factors for visual outcome in patients with Behçet disease. The final visual acuity, there is a significant correlation between the final visual acuity and BOS24. So the authors also demonstrated using the multivariate linear regression, the BOS24 and the BOS24 plus FA findings are the prognostic factor for poor visual outcomes. So in conclusion, FA remains the gold standard in monitoring retinal vasculitis and assessing the response to treatment in Behçet uveitis. OCT is widely used for non-invasive monitoring or macular edema. OCTA allows the visualization of microvascular abnormalities and ocular complications, including non-palpable areas and retinal optic neovascularization. The role of OCTA in monitoring disease activity and decision in the management of patients is yet to be determined. BOS24 scoring system is a quantitative method to assess the ocular disease activity and the useful biomarker to predict the visual outcome in patients with ocular Behçet disease. And I'd like to acknowledge Dr. Okada and the colleagues for the discussion and the suggestion. Thank you for your attention.
Thank you. Thank you very much, Hiroshi, for the wonderful talk. And with this, we move on now to the last talk of our webinar, that is by Pinar Rostel. And Pinar is going to speak to us about update on treatment and visual prognosis in Behçet's. Over to you, Pinar. We can see your slides.
Thank you. First of all, I would like to thank Manfred and Vishali for this kind invitation. Here is my financial disclosure. Behçet disease is known to associate with a poor visual prognosis since 1970s. Although the prognosis has globally improved in recent years, the visual outcome is still guarded, especially in endemic countries like Turkey and Egypt. High rates of visual loss have been reported even in the studies conducted in 2000s. Several reports from different countries have implicated significant changes in disease severity and visual outcome, mostly due to development in treatment modalities. However, changes in environmental factors, awareness of the disease, better compliance, and medication use may also play a role in this change. Considering that the pathogenesis is multifactorial, it is impossible to determine the exact cause of this change. There are several well-known risk factors for poor visual prognosis, like male sex, young age at onset, more than 3 attacks per year, uncontrolled active inflammation, macular ischemia, posterior pole-involved vasculitis, degree of retinal vascular and macular leakage, and hypopyon. But the most important factors determining the visual prognosis in Behçet uveitis are the cumulative damage caused by recurrent inflammatory attacks and occlusive vasculitis and persistent background vascular leakage. So in early and appropriate treatment is the major factor improving the visual outcome, and timely administration of immunosuppressives or biologics improves the visual prognosis significantly. This is a good study showing that from Professor Tutkun. This is a large series comparing patients presented before and after 90s, and show that the risk for visual loss decreased significantly in patients presented after 90s due to more effective use of immunosuppressive agents rather than a tendency toward a milder disease course. And in this study from the same center, that time patients presented in the early 90s and early 2000s have been compared, and patients presented in the early 2000s showed significantly a better visual prognosis, as there was no difference in demographic features and duration of disease at presentation. This improvement has been attributed to earlier and more aggressive use of immunomodulatory therapy, application of combined immunomodulatory regimens, and use of biologics. Another study from another center from National Eye Institute compared 3 decades of treatment response. Compared to 60s, the mean inflammation score decreased significantly in 80s and 90s, and the mean visual acuity increased significantly in 90s, and explained by the decreased use of corticosteroid monotherapy and introduction of corticosteroid-sparing agents and targeted therapy. And this study by Taylor and colleagues showed us that the use of biologics was associated with a lower risk of severe visual loss, both at 5 and 10 years. And not only the treatment modalities or therapeutic agents used, but also the timing is the timing of treatment is very important in the visual prognosis. And in this very nice study by Dr. Kino, conducted by Dr. Kino, compared patients with short disease duration and long duration treated with infliximab, and they showed that induction of early remission is more effective in reducing background vascular leakage and in maintaining good visual acuity. And in this study, a recent study from Egypt, early referral patients and late referral patients have been compared, and it has been shown that having a final visual acuity of less than 200 was more frequent in late referred patients. Our treatment goals are several when treating Behçet uveitis patients. Of course, our first goal is the rapid treatment of acute attacks, and we still need corticosteroids and fast-acting infliximab for this purpose. However, we have to treat chronic subclinical inflammation, prevent recurrences, and achieve a sustained remission, and we need immunosuppressives and biologics for these purposes. As I said before, we still use corticosteroids in high dose for the treatment of severe posterior and panuveitis attacks, as you may see in these 3 different patients. Also, we use corticosteroids together with immunosuppressives as bridging therapy. However, long-term high-dose corticosteroid therapy or corticosteroid monotherapy are no more accepted. Periocular or intravitreal corticosteroids may also be used as an adjuvant treatment to control acute inflammatory attacks and refractory cystoid macular edema, and when high-dose systemic corticosteroid treatment is ineffective or contraindicated. For example, in this case, having chronic cystoid macular edema, despite using high dose of infliximab and azathioprine combination, we applied dexamethasone implant with successful results. And in the study from Turkey, it has been reported that dexamethasone implant is an effective adjuvant treatment in preserving macular anatomy and vision, particularly while switching to biologics. In 27 eyes with cystoid macular edema, despite immunomodulatory treatment, they applied a single injection of the dexamethasone implant and obtained significant anatomical and functional success without serious complication. And our conventional immunosuppressive treatment consists of antimetabolites, T-cell inhibitors, and alkylating agents. And posterior segment inflammation is an absolute indication for immunosuppressive therapy. Within these agents, only azathioprine and cyclosporine have been proven to be effective in randomized controlled trials, and they are the most often used conventional agents. The use of alkylating agents is limited because of their serious side effects and the availability of biologics in nowadays. In severe cases, agents acting faster than immunosuppressives are needed, and these are biologic agents. TNF-alpha antagonists are the most commonly used biologic agents currently because interferon alpha is no more available. In cases refractory to TNF-alpha antagonists, we have some other monoclonal antibodies that we can use as alternative therapy. However, in high-risk patients having acute attack of bilateral posterior segment involvement, severe vascular and capillary leakage at presentation, and severe macular involvement, severe visual loss at presentation, as in this case, we should treat with fast-acting. We should use fast-acting biologics as first line. And in an expert panel about the use of anti-TNF agents, anti-TNF agents are recommended to consider as first-line therapy only for Behçet uveitis, and also in updated Behçet disease recommendations of IOLAR expanded the use of biologic treatment. The according to ELR recommendations, patients presenting with an initial or recurrent acute sight-threatening uveitis attack should be treated with high-dose corticosteroids, infliximab, or interferon alpha. Interferon alpha is an agent proven to be effective in controlling active inflammation and inducing long-term remission even after discontinuation, as you can see in this example. But as I mentioned before, it is not available, unfortunately. Pegylated interferon alpha has a slower absorption and longer serum half-life that permits once-weekly dosing. There are small case series showing that it is helpful in preserving remission obtained by interferon alpha 2A. However, there is no enough data on the use of pegylated interferon as induction therapy, and there is a need for studies to test its efficacy and tolerability. So our current biologic treatment consists of anti-TNF agents. Both infliximab and adalimumab are successfully used for the treatment of refractory Behçet uveitis. They provide a rapid and effective suppression of ocular inflammation by decreasing the severity and frequency of ocular inflammatory attacks and decreasing the optic disc and vascular leakage. They have significant corticosteroid-sparing effect and are well tolerated. When infliximab and adalimumab are compared, higher serum concentrations can be achieved with intravenous infusions of infliximab. So infliximab has a more rapid and potent anti-inflammatory effect starting at as early as 24 hours. However, adalimumab has a lower risk for anti-drug antibodies, has a better patient compliance. It's a better choice for long-term inflammation control, and it is the only approved biologic for the treatment of non-infectious uveitis, meaning that it is available. It is more available compared to infliximab in Turkey, at least. However, primary failure with adalimumab at the current dosing regimen limits its efficacy in severe cases of Behçet uveitis, and severe cases of Behçet uveitis really need for higher loading dose and weekly use of adalimumab. When using anti-TNF alpha treatment, we should not forget that this treatment is associated with increased risk of infection, needing a careful screening prior to therapy and follow-up for drug-induced autoimmune diseases and the myelinating disease. Anti-TNF treatment can be used as monotherapy or with concomitant immunosuppressive therapy, as we do in our current practice in Turkey. Failure of one anti-TNF alpha drug does not predict a poor response to a second one. So switching between infliximab and adalimumab is recommended in patients with primary or secondary failure. When to switch the treatment is an important question to be answered. Prevention of recurrent attacks can be provided by the treatment of persistent leakage on fluorescein angiogram. So our ultimate goal when treating a patient is to achieve a dry fluorescein angiography. And if there is persistent leakage, new attack even mild, and development of cystoid macular edema while on treatment, we should either intensify or switch our treatment. Here in the example for this patient was referred by a rheumatology clinic and was using azathioprine only. And we saw that this persistent vascular and capillary and optic disc leakage on fluorescein angiogram. We add infliximab to his azathioprine therapy. And in patients having recurrences with currently used anti-TNF agents, instead of using high-dose corticosteroids, we decrease the intervals between infliximab infusions or adalimumab injections, or switch to another biologics, mostly tocilizumab, golimumab, or anti-IL-1 agents. Golimumab has been shown to be effective in small series by the effective resolution of retinal vasculitis and reduction of ocular attacks. And there is an ongoing phase 2 clinical trial evaluating its efficacy and safety in refractory cases of Behçet uveitis. Tocilizumab also has been reported to be effective in a small series. This series from Istanbul from Dr. Tutkun showed that tocilizumab is effective in providing clinical inactivity, reducing flare values, and reducing fluorescein angiography. And in this series, this small series from Spain, a complete remission could be obtained in most of the patients. Interleukin-1 inhibiting agents are safer in terms of the risk for opportunistic infections. However, clinical experience is limited. There are again a few small series showing that it is effective both in refractory and long-lasting cases and as first-line agent. And when to stop the treatment is also an important question, and there is no consensus about. Decision for stopping the treatment should be taken cautiously, and clinical quiescence is not enough for taking this decision. Clinical inactivity should be confirmed with no leakage on fluorescein angiography and monitorization of flare levels if available, of course. What we do in our current practice, if there is a clinical inactivity for at least 2 years and no leakage on fluorescein angiography, we start to optimize the treatment and continue to treat for an additional 2 years. We repeat the leakage, and if we repeat the fluorescein angiography, and if there is no leakage again, we stop the treatment. For example, in this case, there were new lesions while on azathioprine and cyclosporine therapy and interferon. So we switched to infliximab in this patient. We used infliximab for two years. He had no attacks during these 2 years and no leakage on fluorescein angiography. We started to increase, to prolong the intervals of infliximab, and continued to treat 1 more year. And then we repeated the fluorescein angiography. There was no leakage, and we stopped the infliximab and continued with azathioprine only. So to conclude, although a tendency towards the milder disease course has been observed in recent years, Behçet uveitis is still a disease with a poor visual prognosis. In early and appropriate treatment and adherence to treatment of patients are the most important factors determining the visual prognosis. Behçet uveitis needs a powerful treatment once the diagnosis is made. Treatment should be tailored according to the severity of disease. Corticosteroids should only be used for the treatment of acute attack, and a stepwise therapeutic approach is adopted. The first-line treatment is still conventional therapy consisting of corticosteroids, azathioprine, and cyclosporine, and the second-line therapy is biologics, consisting of infliximab and adalimumab. However, in patients presenting with severe sight-threatening posterior segment involvement, biologics should be used as first line. Treatment should be switched in patients with new inflammatory attack and persistent leakage and associated complications. And in patients having recurrences with currently used anti-TNF agents, we should optimize the treatment or switch to another biologic like tocilizumab, golimumab, or anti-IL-1 agents. And we have some potential future treatment agents like JAK inhibitors, low-dose IL-2, ustekinumab, but we don't have enough data about their use in Behçet uveitis. And finally, our ultimate goal in the treatment of Behçet uveitis is the cure of the disease, which means to achieve a durable, sustained remission. And there are still patients refractory to the currently used conventional and biologic agents. So new therapeutic agents and approaches are still needed to provide a drug-free remission with 20/20 vision. And there is still an unmet need for randomized controlled trials addressing Behçet uveitis specifically. Thank you for your attention.
Pınar, thank you. I think, yeah, Manfred, you are here because Vishali wrote to me that she would be leaving. Okay, since you are here, please go ahead.
So thanks to all of the speakers. Very lovely presentations, more or less also very nicely in time. I think we should allow a little bit to give a chance for the controversies. So let me start with these controversies. I was very surprised about the role of B51. This is amazing. Question to all of you. These questions are always actually to all of you. Is there a real clinical difference or a study about clinical difference between 51 positive and 51 negative Behçet's patients? So people which fulfill all the criteria, B51 is not part of the criteria, but in this regard, is there a difference, clinical difference? Let's start with Ahmed, probably, rheumatologically a difference?
Well, I can start by saying that B51 positivity is strongly associated with the typical clinical phenotype, including uveitis, and gentle ulcers. And especially if you look at the frequency of B51 in patients with ocular disease, which is actually much higher compared to the average B51 in Behçet's patients. Usually in Turkey, about 60 to 70% of Behçet's patients have B51. But when it comes to patients with uveitis, it's usually exceeding 80%, which means that patients with typical ocular lesions usually have B51. And there are, of course, other weaker HLA associations, very similar to A26, and maybe other HLA alleles are also contributing. So one of the class 1s, B51 or other weakly associated HLA alleles, probably contributing. But when it comes to the disease phenotype in B51 negatives, well, B51 negatives, if they fulfill the criteria, they more or less have a similar clinical picture. But if you are specifically talking about uveitis, majority of typical uveitis patients will have B51. So it's defining the phenotype.
Yeah, Ilknur and Pina and Ahmed, what do you think about the clinic on the eye? Do you see any difference between 51 positive and negative? Is there a study?
Haven't done any formal study. There are publications showing more severe disease in B51 positive patients, like a risk factor, prognostic factor. I have not looked at it because we don't routinely perform HLA typing in our Behçet patients. But from like occasional experience, I mean, it's hard to tell because, as Ahmed said before, most of the patients are B51 positive, the uveitis patients. The number of negative group is small to gain any significant clinical experience, you know what I mean. But I would expect that the disease to be milder probably in B51 negative cases, but it's just clinical impression.
Be interesting to analyze.
Manfred, I think, Manfred, it is not possible to answer this question because I know that most of the centers, they don't do routinely HLA-B51 testing in their patients. Unless you plan for a prospective study, then you can find the answer. But in our clinic, we never rely on HLA-B51 testing to make a diagnosis.
Well, my opinion is that a lot of these patients come in already with B51 positive or negative, so we don't have to do the testing anymore. Other one did that because they don't know that this is not part of the criteria. So, but that would be an idea probably.
Yeah. I can also add about the severity, because there was a question and I answered that one. You know, we actually formally investigated the role of B51 or homozygosity of B51 on the disease severity. But it depends again, the definition of disease severity. If you just take those patients with ocular, vascular, or neurologic disease, well, B51 is definitely much frequently found in patients with ocular disease. But within ocular disease, B51 itself is not the major determinant. We know this issue even from B27. You know, B27 is defining a clinical picture, but when it comes to disease severity, there are other genetic factors or environmental factors affecting the severity of manifestations.
Well, regarding B27, my impression is that men definitely have this more severe disease, and women are less B27 positive, but they still get severe disease. So it doesn't play a role if you're B27 positive or negative. So that's something we also only test because of, well, scientific use. Let's go to the next one, cytokines. Ahmed, that's a question actually for you. Did you also analyze your different patterns between patients who developed macular edema and no macular edema? I think that makes a lot of sense because the cytokines not only produce normal inflammation like AC cells or something like that, vitreous cells. The major problem is, besides ocular vasculitis, occlusive vasculitis, the macular edema. So do you see any difference in that pattern?
This is a very important question, Manfred. Unfortunately, we did not look specifically at macular edema. We were mostly interested in looking at the difference between acute non-granulomatous uveitis, HLB27 and Beheet versus granulomatous VKH and sarcoidosis. But we did not look specifically at the difference in, for example, as you know, in VKH patients, very rarely we see macular edema. But we did not look specifically for the effect of macular edema.
But that's something probably in retrospective you can check for your Beheet group. Yes. And I think it makes a lot of sense if this predicts actually macular edema. I think I'm not that positive in the way that you can really predict a lot from your for the coming clinic from all these cytokines. But I think regarding the pathophysiology, it's extremely interesting and helpful.
But what we did, Manfred, and we published this already, we in some patients, we had aqueous samples at presentation with an active disease. And after completely controlling the inflammation with conventional immunosuppressive or biologics, and we could see dramatic reduction, especially of IP10, which is a marker of T helper 1, which is a chemoattractant for T helper 1 cells, and also the neutrophil chemoattractants after treatment. So I would assume that because when the disease is controlled, macular edema also is controlled, that the reduction of cytokines and chemokines had a very important, useful effect on macular edema.
But we know that in TNF-alpha blocking agents are much less effective against macular edema than, for example, interferon alpha, which you, I think, have not done. So it would be very, very lovely to actually to get AC taps from people treated with interferon alpha. And that's actually one of the next points.
But Manfred, here you are raising an important point. I have some patients on infliximab. They are clinically, they are controlled, but they have persistent edema.
Yeah.
And these patients, as has been suggested, especially if they are pseudophakic, they benefit from intravitreal Ozurdex. And one injection of Ozurdex can give an effect that can last for a year.
Yeah.
But
I think
interferon alpha is a very good option in that case. I mean, for
Which one?
persistent macular edema, that's the most effective, fast-acting agent.
Which one? Igno, can you
Interferon
repeat this?
alpha. Interferon alpha.
Unfortunately,
Definitely.
it is not available in our country.
I know, but
Well-
we have pegylated interferon alpha, which is mostly effective after 1 or 2 weekly injections of this depot form. I mean,
yes.
Behçet patients, also non-Behçet uveitis patients with persistent macular edema, beautifully respond.
Which company produce it? Which company?
Hoffmann Roche, I guess. Still Hoffmann Roche.
Yeah.
Yeah, they
Pegylated
changed
one,
from the normal one to the pegylated one. But the
Pegylated
dosage
form.
is a little bit more individual. Yeah, so it's not that easy that you can follow a simple diagnostic scheme. But I would agree it's as effective as the other one. Yes. One more point to the treatment and to interferon alpha. I think we have to decide 2 different points in our treatment. The final outcome is the most important, I agree, but the steps are different. Step number 1 is we need an effective drug if the inflammation is reduced. And we have a lot of these effective drugs. Even steroids are highly effective, but if you stop these drugs, and that's the same actually also mostly for the TNF-alpha blocking agents, then the whole thing comes back. And with interferon alpha, we have shown for years that these people stay quiet. In case they show a new recurrence, you simply restart with this one. Yes. So I still think that interferon alpha is definitely really a wonderful chance for severe patients. And especially also, we have shown the fantastic, Ilknur, you too, the fantastic visual outcome over years, yes. And the Paris group and the Berlin group have shown these are reproduced results. So I strongly would recommend to restart interferon alpha, but of course a pegylated form. It needs a little bit introduction, probably also from you, Ilknur, regarding the dosage. It needs a little bit different handling. Our patients with the pegylated form are more happy than the other ones which have to inject this every day. Yes, it's definitely nice. But I think that's how we should treat our patients. The goal in mind is that this disease is quiet for a long time, even if they don't have such drugs. Yeah. So if you have other drugs, I'm fine with that one. Ilknur, any comment to this treatment?
Well, with interferon alpha, I mean, the pegylated form, as you said, the patients are happier because there is less side effects, the flu-like side effect. I mean, it is less pronounced, let's say, compared to the daily high-dose treatment. And either with 135 micrograms or 180 for Pegasus, pegylated interferon alpha 2A. Both doses work similarly, and I start with weekly dosing and then extend the dosing intervals, looking at the liver enzymes again and complete blood counts. That's important after 2 or 3 injections. But patients tolerate better than the standard interferon alpha. I believe interferon alpha is still produced in India, in China. Maybe Faizeng can comment on this. Also in Iran, they have their local production. So I tell my patients who have difficulty in finding interferon alpha, if they have any means of getting the drug from these countries to obtain in that way. There are like pilots and people who travel, so it may be an option. That's what I know from the literature. Please, Faizeng, do you still have interferon alpha in China?
You're muted.
Alpha in the treatment of Behçet disease, and recently we compared the effectiveness of interferon alpha and anti-TNF, the result, and we didn't find a difference between these 2 groups. Though we think interferon alpha is very useful for some patients, but not for all of the patients.
Very individually.
Is it available in China?
Yes, yes. Yeah.
Okay, some more products from China we get.
Ikno, from where do you get your pegylated interferon alpha?
It's still found in Turkey, but in very, limited amounts, I believe. Patients have difficulty in finding it because interferon alpha is no more used in hepatitis patients. It's out of the market. But we still have the pegylated form that is used for different purposes, not for only uveitis. Interferon beta is still there for MS uveitis, but from my personal experience, I don't think it works even in MS uveitis. There are publications in favor of interferon beta, but it's not the same drug.
Pegylated interferon alpha is commercially available. That's what
yes,
like
it is available, still available in Turkey. I hope it will stay available.
Okay.
So my final comment goes to Pai Zhang, actually. Thanks so much for your lovely, important microbiome studies. This is amazing. And we'll have the pleasure to hear that probably with some additional findings already in Utrecht in the Beheet session. How do you want to progress with the microbiome studies? What are the plans, more or less, if you can tell about this?
Yes. Okay, thank you very much, Manfred. Right now, we do the experiment about the peptide of the gut microbiome and the IRBP peptide, the similarity between this. Also, we have done some research about the gut microbiome on the stimulation of neutrophil. My student, PhD students, they have done a lot of work and can answer the question.
Yeah, my next plan investigation on disease of gut microbiome is to compare with other autoimmune disease or autoinflammatory disease to find the specific gut microbiome signature.
Yeah, to identify if our results were specific to Beheet's disease or could be expanded to other autoimmune diseases.
So we compare the result of Beheet disease and the BKH syndrome.
Oh, well, we see, yes. I would not be too disappointed to see not a difference. In my understanding, I think one of the major problems is that there is some kind of confusion in intestinal endothelium, and when that finds the correct genetic or some other structures, then aggressive T cells, autoaggressive or whatever, TH1, TH17 cells are started to get produced, and that's probably the major impact. But probably we'll see some kind of transplantation in the near futures from China coming. That would be really a very innovative treatment for Beheet's disease. Okay, so I think we are a little bit over time already, 12 minutes. Sorry for this one. Thanks so much to all of you. If you have some time and you feel that some of these questions are for you, please go through the question and answers and answer these questions from our participants. Otherwise, thanks so much. We'll meet again with all the listeners too in approximately 4 weeks for the next webinar. Thanks so much.
Thank you.
Okay, thank you. Bye-bye.
Bye.
Bye. Thank you.
Bye.
Bye.
Manfred.
Yes.
I wish you rapid and complete cure.
Thanks so much.
Yeah.
Well,
Me
as long
too.
as
Get well
I'm,
soon. Yeah.
Yes.
well,
Thank
get
you,
not worse.
Manfred, for everything you have done
I-
in IUSG. I mean, we cannot thank you enough, all of us.
You can do that, definitely, yes. By co-working for the things I've sent you, for example, yes, we definitely need your help for these things. And, you know, in the moment, it's a situation where I try to finish a few things and to do things, important things. For example, I've booked again seats for the next Venice meeting in February. If I cannot do that, that will become a consortium of, let's say, 4 or 5 people, which then cover that one. But I think it's an important procedure and important for the ISG, important for the young generations to learn there. And it's not so difficult to handle these things, and well, something like that one. So looking straight forward, in the moment, I'm more or less happy, but the treatment is limited. That's the point. Okay, please have us look for the question and answers. Yes.
Okay.
See you to the next meetings.
Yeah. Thank you, Manfred.
See you. Bye-bye.
Pleasure.
Thank you, Manfred.